This last video in the pain and opioid video series will cover opioid pharmacogenomics. Specifically, this video will focus on codeine metabolism and the polymorphic nature of the codeine metabolizing enzyme CYP2D6. Codeine is an opioid agonist drug that must be metabolized in order to be active in the body. Said another way, codeine is a prodrug that has to be metabolized to the active metabolite morphine in order to produce pain relief or analgesia. The enzyme responsible for activating codeine is the P450 enzyme CYP2D6. CYP2D6 is polymorphic in the normal population, meaning that different individuals have different levels of CYP2D6 activity. The level of CYP2D6 activity dictates whether or not an individual will have a normal physiologic response to codeine, or whether that physiologic response could potentially be toxic. First, I will review the possible phenotypes of the CYP2D6 enzyme and the genotypes or diplotypes that lead to that outcome or phenotype. The first phenotype I'll talk about are extensive metabolizers. This comprises the majority of patients at around 77 to 92% of individuals. These are individuals with normal activity of the CYP2D6 enzyme because they have two alleles that encode full or reduced function CYP2D6 enzyme. If an individual has more than two copies of functional alleles, this individual is considered to be an ultra-rapid metabolizer, and that is about 1 to 2% of patients. These individuals have a higher than normal activity in the CYP2D6 enzyme, and therefore it converts codeine to morphine more rapidly. Just below extensive metabolizers are intermediate metabolizers, comprising 2 to 11% of patients. These individuals have a slightly reduced activity of the CYP2D6 enzyme due to the presence of one reduced function and one non-functional allele of the CYP2D6 gene. Finally, there are poor metabolizers, which comprise 5 to 10% of patients. These individuals have completely non-functional CYP2D6 enzymatic activity because they carry no functional alleles. In these individuals, codeine is not converted to morphine at all. Because there are literally hundreds of combinations of CYP2D6 diplotypes, the best way to determine the activity level of a diplotype is to consult a table like the one shown here. So for example, if I gave you a diplotype of *4, *4, you would be able to look at this table and determine that individual is a poor metabolizer. As another example, a *2, *2 diplotype is considered an extensive metabolizer. There is no need to memorize these diplotypes. There are far too many to recall them all. The easiest way to determine the activity of a given diplotype is to consult resources. In reality, there are hundreds of allele combinations that can lead to different outcomes with regard to CYP2D6 phenotype or activity. Another way to look at this is to visualize CYP2D6 activity due to genetic variation as a continuum from 0% activity all the way to 100% and even in some cases higher than 100% activity of the enzyme. Poor metabolizers are individuals with non-functional CYP2D6 enzymatic activity. Their activity score and their percent activity are 0. Intermediate metabolizers, again, these are individuals with slightly lower than average or slightly lower than normal enzymatic activity, have activity scores in the ranges of 0.25 to 1, and the enzyme in that case is about 25% to 75% functional. Normal metabolizers, also called extensive metabolizers, are considered to have normal enzymatic function, and this is the majority of individuals in the population. The activity of the enzyme is somewhere between 1 and 2, and their percent activity is somewhere between 75% and 100%. Finally, ultra-rapid metabolizers have increased enzymatic activity, with activity scores above 2 and percent activity above 100%. Said another way, poor metabolizers do not metabolize codeine at all. Intermediate metabolizers metabolize codeine more slowly. Normal metabolizers do so on an extensive basis, meaning it's fully metabolized. And ultra rapid metabolizers convert codeine to morphine much more rapidly than normal. The next and most important consideration is, what do these changes in CYP2D6 phenotype mean for clinical dosing or administration of codeine? I'll start with the extensive metabolizers because, again, this is the majority of the population and what is considered normal. These are individuals that metabolize codeine to morphine normally, and one is able to use label recommended age and or weight specific dosing for these individuals because codeine is converted to the active drug morphine at the expected rate. Next, we'll move one level up in the table and talk about ultra rapid metabolizers. Again, these are individuals that convert codeine to morphine more rapidly than normal. And the implication here is that you have higher levels of morphine in the bloodstream, which can lead to potential toxicity. Therefore, in these individuals, the clinical recommendation is to avoid codeine use in ultra-rapid metabolizers due to the potential for toxicity from side effects such as respiratory depression. In this case, any alternative opioid that is not metabolized by CYP2D6 is a reasonable alternate, including morphine as well as the non-opioid analgesics. Even though we've been discussing primarily codeine here, other drugs that are metabolized to their more active metabolite by CYP2D6, including tramadol, hydrocodone, and oxycodone, are not good alternatives because their metabolism is also affected by CYP2D6 activity. Next, we will look at the intermediate metabolizers. Again, these are individuals that convert codeine to morphine slightly slower than normal, so there is reduced formation of morphine. However, this reduced formation is not typically clinically relevant, and so you can still use label recommended age or weight specific dosing. However, if the CYP2D function is so low that there is no response to administration of codeine, the recommendation is to consider an alternative analgesic that is not metabolized by CYP2D6, such as morphine. Tramadol can also be affected in individuals who are intermediate metabolizers, and therefore tramadol use should also be monitored for a response in this case. In poor metabolizers, these are individuals with greatly reduced formation of morphine from codeine. And because codeine is not converted to morphine at all, there is typically insufficient pain relief in these individuals. The recommendation here is to avoid codeine use due to lack of efficacy. An alternative could be an opioid that is not affected by CYP2D6 metabolism, like morphine. Tramadol, hydrocodone, and oxycodone are not considered good alternatives in this case because, again, as I mentioned before, their metabolism is also affected by CYP2D6 activity. To summarize, codeine and other codeine-derived prodrugs, including tramadol, hydrocodone, and oxycodone, can be used at label recommended age and weight specific dosing in extensive and intermediate metabolizers. However, they should be avoided in ultra rapid metabolizers due to the potential for toxicity, and they also should be avoided in poor metabolizers due to the potential for lack of efficacy. In cases where an alternate opioid is recommended, alternatives that are not affected by the CYP2D6 enzyme are preferred, and these include agents such as morphine as well as the non-opioid analgesics. Take a moment to practice applying these concepts to a clinical situation. What would happen when a standard dose of codeine is given to a CYP2D6 poor metabolizer? What would be the physiologic consequences? What are the pharmacogenomic reasons underlying these differences? On the other hand, what would happen when a standard dose of codeine is given to a CYP2D6 ultra-rapid metabolizer? What are the physiologic consequences in this case, and what is the pharmacogenomic reason underlying this difference? Snap a pic of the QR code on the screen if you need help answering this prompt.